Hi guys, this is Ada Ojaid from Med Lectures Express, back with another video titled Step-by-Step Approach with Allergic Rhinitis. This video focuses on a case review of a 30-year-old female patient who presented to the clinic with nasal and ocular symptoms. Disclaimer: the case is fictional. Resources used for the video include Netter's Internal Medicine, other medicine texts, AAFP, and FP Notebook. Ms. Veda is our sample patient for a case review. Ms. Veda is a 30-year-old female who presents to your clinic with chief complaints of sneezing, runny nose, and bilateral itchy eyes. Patient's history include the following: history of seasonal allergies, uses OTC remedy, mild childhood atopic dermatitis without further flare-ups, childhood asthma, recently relocated to Georgia, is allergic to penicillin. Also another image of atopic dermatitis. What important historical data would you obtain? How would you proceed with obtaining it? If you are thinking along similar lines as I am, the first question you need to ask is the onset of symptoms. What happened prior to the onset of symptoms or at outset? These historical questions will include the following: 1, the onset of symptoms; 2, the quality of symptoms; 3, extension of symptoms to adjacent structures or radiation of symptoms; associated symptoms; actions that aggravate symptoms; actions that relieve symptoms; previous episodes of the chief presentation or the chief complaint. Next, other important historical data you need to obtain will include also the following: determine if patient is on any of the following medications: beta blockers, acetylsalicylic acid aspirin, NSAIDs, ACE inhibitors, recreational drugs, hormonal therapy, or OCPs. You need to ascertain if patient can identify triggers such as environmental or seasonal, history of atopy, history of common cold, URI, chronic respiratory disorders. Also, you need to inquire about response to treatment for previous exacerbated episodes. Here is a summary of your history interview of our lovely patient. Symptoms started 2 weeks ago. Quality of symptoms: mostly nasal symptoms with congestion and slight hyposmia, clear drainage, mild breathing at times. Patient reports nasal symptoms to be greater than ocular or any other associated symptoms. Extension of symptoms: patient reports itchy throat, feels drainage dripping down throat, mild cough at times, eyes itching periodically, eyes more reddened today per patient. Patient also reports ear fullness as an associated symptom. Also had trouble initiating sleep, but did sleep well last night. Actions that aggravate symptoms: patient reports symptoms worsening when outside. Actions that relieve symptoms: patient tried OTC oxymetallazine, which is a nasal decongestant, but had reports minimal effect. Also, patient reports that being indoors decreases symptom severity. Patient reports that in the past had experienced mild episodes and also has had an exacerbated episode 4 years ago. Summary of patient interview continued. Patient denies use of any contributing medication. does report allergies to pollen, bees, grass, reports bouts of sneezing during spring season. Patient also reports a history of childhood atopy, otitis media, and viral rhinitis. Patient also reports that in the past was prescribed intranasal corticosteroids with maximum relief, and this happened 4 years ago. Now that you've completed the history interview, what historical data do you think will help with developing your diagnosis? Which data is clinically viable? The viable clinical data include the following. 1. Nasal symptoms greater than ocular or other associated symptoms with allergic component. So that's what I'm noticing from everything that the patient has verbalized and expressed. Patient also reports bilateral eye injection, and I can see that while I'm doing the history interview, reports postnasal drip. Patient reports that symptoms worsening when outdoors. Patient also has a history of childhood atopy, which is also a predilection for continued presentation of other atopic disease. Patient does have an itchy repertoire that involves the nose, eyes, and throat. As you perform the physical exam, you note the following. Allergic shiners, right here. They are considered infraorbital edema and darkening or bluish purple ring around the eyes. You also noted a transverse nasal crease right here. It's very faint, but it's right here. You also noted cobblestoning around the posterior pharynx, which is right here. And you observed a postnasal drip. You also noted swollen pale turbinate or pale boggy turbinate, enlarged turbinate. This is the normal physiology of normal turbinate, and this is alteration via allergens or any other mechanism. Clear nasal drainage via otoscopy. You can clearly see that there's a clear nasal drainage right here. This is also more image to help reinforce the imagery of cobblestoning, and it's a likeness of a cobblestoning. This is another image just to, for your reference, more high definition or more like focused image of cobblestoning. Also, other examinations like other physical exams, including the vital signs, were unremarkable. Differential diagnosis of rhinitis. At this point, I'm thinking of an URI diagnosis. So this is a comprehensive list of differentials for rhinitis. So at this point, I'm thinking of ruling out a more fulminant or severe or life-threatening disease. You can pause the video at this point to review content, and you can use this for your reference. So these are the different differential diagnoses for allergic rhinitis, non-allergic rhinitis, conditions that mimic symptoms of rhinitis. They're all here. But whenever you're developing differential diagnosis for a patient, the most important thing is to be able to rule out red flags and to rule out life-threatening conditions, and also to make sure that before you attempt doing all this, that your patient is clinically stable. Differential diagnosis of rhinitis. This image is more a list of differentials for your reference, so you can also pause the video at this point to review the content of the image and we have allergic rhinitis, infectious rhinitis. Main pathogen is viral, non-allergic, non-infectious, and non-allergic rhinitis is typically caused by, it's typically common in pregnant women, and it could be also hormonal, like hypothyroidism, and other, it can be idiopathic or just have other forms of mechanism that precipitates it. Also, rhinosinusitis is a major differential for rhinitis. So just use this for your reference. It's also good to memorize it. So especially for students in school, you can recall it quicker when you're in clinical. Okay, this image shows the mnemonic for differential diagnosis and etiological classifications of signs and symptoms. You need to try to memorize it. It's vindicate. So V stands for vascular, I is for inflammatory or infectious, N is for neoplastic, D is for degenerative, deficiency, drugs, I is for idiopathic. So it's really important for you to memorize this, and you can use it for your reference. This is going to help you to arrive quickly at a, be able to develop your differentials and arrive quickly at your most likely diagnosis, or, help you to confirm your diagnosis in a clinical setting. So at this point, taking into totality the clinical presentation, the history interview, and the physical exam, I am leaning towards allergic rhinitis because there's a huge allergic component to the patient's presentation. That's one of the reasons. But I've not confirmed it yet, but I'm leaning towards that. So I provided these images as cues to help us to both think in the right direction. Allergic rhinitis symptoms is red, itchy, watery eyes, sneezing, congestion. These are hallmark symptoms of rhinitis. Itchy, sore throat, fatigue. Also, other URI can have these symptoms too, but everything, in taking into consideration everything that the patient narrative is showing, I am leaning more towards allergic rhinitis. And here you have the allergic shiners. And these are just more pictures and images to just help you kind of be able to recognize rhinitis when you see it in your clinical setting. So this is what this is about. Now that you've carefully mastered the cues provided, what is your working diagnosis? How do you know you're going in the right directions? Things to consider at this point. 1. Active recall of nasal pathology. You need to have a good grounding on nasal physiology and alteration of the nasal passageways. 2. Consideration of presentation pattern in your clinic or the epidemiology of rhinitis or URI in your clinical setting. 3. Patient's history of atopic disease, likely caused because of previous IgE sensitization. Relocation to a place of lush greenery and prevalence of outdoor allergens, Georgia, hence Georgia. Paroxysms of sneezing and intermittent pruritus of throat and mouth and eyes. Pertinent positives from the physical exam and also from the history interview. So in totality, and considering everything, my working diagnosis is rhinitis of some sort. I just need to figure out what kind of rhinitis, so we'll figure it out together. What do you think is the most likely diagnosis? 1. Active recall of likely etiology based on your knowledge of pathophysiology, physical diagnosis, clinical patterns, and geographic epidemiology. So that's where I come about IgE mediated response to aerosolized allergens via mast cell degranulation, release of histamine, leukotrienes, and T helper to cell recruitment. So I already know from just knowledge grounding and just by memory and just recalling information without looking at any material that this etiology is allergic in presentation. Not only that, it's leaning towards allergic rhinitis because of what the clinical picture is showing me. So that's how I arrived at this. But this is just one component of making a likely diagnosis. You need a solid grounding in pathophysiology and physical diagnosis and just epidemiology and clinical patterns. So the IgE is what is precipitating the symptoms that the patient is having. Second, the most likely diagnosis is allergic rhinitis. Subtype is seasonal, is the most common form of rhinitis. Oh, sorry, not the most. Subtype is seasonal, and allergic rhinitis is the most common form of rhinitis. That's what that means. It's greater than 40% in prevalence. Allergic rhinitis is typically diagnosed clinically based on the whole presentation and the whole patient narrative. If recurrent, skin testing and allergen specific IgE levels is necessary, and this is according to other evidence-based panels. 3. The particulars that help me arrive at this diagnosis include the following: sneezing, watery eyes, pruritic eyes, and rhinorrhea. Also, the pertinent positives from both history and physical exam, history of atopy, recent migration to Georgia, previous episodes of allergic rhinitis. So, taking into consideration, as previously mentioned, all the totality of the narrative of the data, I can confidently say that the most likely diagnosis is allergic rhinitis. Important point with differentials, with developing your differentials or developing your most accurate diagnosis, is you have to make sure that you rule out. It's really important. You rule out the most critical or life-threatening. And the reason why I can confidently go ahead and make the diagnosis of allergic rhinitis is because I've determined that my patient is hemodynamically stable, as evidenced by unremarkable vital signs. The vital signs are normal, and also the moderate nature of the patient's illness. So that's given me confidence to say, okay, I can go with allergic rhinitis. And also the pathophysiology, the clinical presentation, and also the national epidemiology or the clinical epidemiology of rhinitis. Most cases, allergic rhinitis is the most common of all types of rhinitis. This image shows classification of allergic rhinitis according to symptom duration and severity by ARIA. This is adapted from Allergy, Asthma, and Clinical Immunology journal. We have intermittent persistent. Intermittent is less than 4 days. Persistent is symptoms greater than 4 days. And then you have mild. They have a normal sleep, no impairment, normal work and school function. So please pause the video to review the content and use this for your reference. This image shows symptom severity and subtypes of allergic rhinitis. Please pause the video at this point to review the content, memorize it, and use it for your reference. This image shows treatment algorithm for allergic rhinitis. And this was adapted from AAFP. You can pause the video at this point and review the content and use it for your reference. Also, remember, do not prescribe nasal decongestants for more than 3 days. More treatment algorithm for allergic rhinitis. Use this for your reference. Management principles, putting it all together. This is a snippet of the management principles. Allergen avoidance. Avoidance of triggers is fundamental to treatment. Second generation oral antihistamine may be used as first line for symptoms of mild severity. Intranasal corticosteroids for patients with mild or persistent symptoms or moderate or severe symptoms. This is considered gold standard for treatment. Intranasal corticosteroids, gold standard for treatment. Combination intranasal corticosteroids and antihistamine nasal spray was found to be more effective in moderate, severe, or resistant cases of allergic rhinitis. This requires specialist referral. These patients may also have comorbid asthma, and also they have treatment failure from empiric medication. Next, leukotriene receptor agonist, a combination of LTRAs and antihistamine have been found to have equal efficacy to intranasal corticosteroids. This is indicated for people who have refractory episodes. Singular therapy with LTRAs are rarely indicated. When you get to this point, it also requires a specialist referral. Allergen immunotherapy, also for severe disease process, requires specialist consult. ARIA recommends allergy testing with initial diagnosis, but other evidence panels recommend allergy testing and blood serum testing for recurrent or severe episodes. This image shows intranasal options to treat seasonal allergic rhinitis. You can use this for your reference. How do we manage Miss Vita? First, we have to determine symptom severity. We've determined that her symptoms are persistent. That means it's greater than 4 days weekly. 2, we're going to educate her on allergy avoidance. We're going to reinforce avoiding triggers. Next, we're going to prescribe intranasal corticosteroids such as Flonase. Intranasal corticosteroids are considered superior to combination therapy for mild or persistent symptoms. Next, we're going to prescribe topical ketotifen for ocular itching. Next, we're going to recommend saline irrigation for symptom relief, also found to help with relief of nasal congestion. Next, we're going to schedule patient for intradermal allergy testing. This is per BSCA guideline. However, other evidence panels recommend skin testing after empiric failure. I just want to thank everyone for supporting our channel and for watching our videos. If you have any questions, please put in the comment section. We really appreciate your support. Thank you.